Dr. Rader, thank you so much for joining us on MD Newsline. Can you please introduce yourself to our audience?
Thanks for this opportunity. My name is Dr. Ryan Rader. I'm a clinical assistant professor at the University of Kansas Cancer Center. I work at a community site at the Lee Summit, Missouri location, where I predominantly see patients with breast cancer. I also am a board certified hematologist and oncologist, so I can see a myriad of patients, but I'm very privileged to have a very active breast cancer patient part of my population.
Mhm. And breast cancer is always a hot topic, and recently there have been some talk about trends. So please let me know, what trends are you seeing in the clinical presentation of breast cancer, specifically among younger and premenopausal patients?
Yeah, so unfortunately, and we see in data from the CDC as well as anecdotally in my own patient practice, I'm seeing more and more patients that are presenting at younger and younger ages, even in their 20s. Women who have breast cancer at young age, defined as less than 45 years of age, unfortunately have a more aggressive phenotype. And by phenotype, what I mean is when I treat breast cancer as a medical oncologist, that means I deal with treatments like chemotherapy, endocrine therapy, targeted therapy, treatments that affect the whole body. When I see a patient with breast cancer, the main thing that I'm looking at in order to help direct treatment is what is driving this breast cancer. So when we do a biopsy of breast cancer, we're looking to see, is there estrogen receptors present on the breast cancer tissue? Are there progesterone receptors? And then a protein that's called HER2 that's normally expressed on breast tissue but can be hijacked in the growth of breast cancer cells. And so the estrogen, progesterone, and HER2 statuses are critically important for optimal treatments. We see more patients that have more aggressive signatures for those. So triple negative breast cancers that don't have estrogen, progesterone, HER2, or that are HER2 positive, which generally are known to be more aggressive, but we have made tremendous advancements in the treatments of HER2 positive breast cancer across all stages. So unfortunately, we are seeing an increased uptick about 1% per year in patients in that demographic with new diagnoses of breast cancer year over year.
And with these kind of this new crop of patient types that seem to be going up year after year, in your experience, which initial signs or symptoms tend to make early breast cancer diagnosis more challenging in everyday practice?
So, breast cancer screening is critically important in the early diagnosis of breast cancer. And current guidelines vary depending on which organization, but essentially, starting at age 40, unless you have increased risk factors, the general population's recommendation is to start mammograms at 40. And so a lot of women, when they're in their 30s or 20s, are detecting this with palpable masses. And what can be challenging is oftentimes women that are premenopausal can have fibrocystic changes of the breast, so they can notice changes in their breast tissue. They can notice, lumpy, bumpy breasts. Then that can come and go with their cycles. So it's the masses that come and stick around that can be disconcerting and should definitely be a warning sign to get that evaluated by your healthcare provider.